On behalf of EGFR Positive UK, welcome Dr. Anna Minchom. Dr. Minchom is a consultant medical oncologist at the Royal Marsden and the Institute of Cancer Research, and is part of the drug development unit and has a special interest in clinical trials, specifically relating to lung cancer. So we're delighted that she's joined us today to, I think, demystify, explain clinical trials from a patient's point of view. I think Deborah just wants to welcome you from the outpatient's point of view as well.
Yes, welcome, and thanks very much indeed for doing this talk this afternoon. So thank you once again for giving up your time for us.
No problem at all, and thank you for the introduction. I don't have much to add to that. I'm an oncologist. I work in a Marsden, and yes, I run clinical trials, both in the drug development unit and in the lung unit as well. And yes, I hope over the next 20 or 30 minutes or so to be able to really give you a user's guide to clinical trials. And I'm very happy to be interrupted as we go along or take questions at the end. But what I hope to cover is what are clinical trials and explain what are phase 1 trials, phase 2 trials and phase 3 trials, because this is what is categorized very often, and it's sometimes difficult to work out exactly what a trial is about. Talk to you a little bit about what it entails participating in a clinical trial, what it's like to try and get on a clinical trial in terms of the processes that need to happen, and then a little bit about how to access clinical trials if it's something you're interested in, and where to access them. And to start with, probably the best way to think about clinical trials is to think of them as the steps that need to go through when you're taking a drug from when it's just been designed and it's been tested in a laboratory, right through until a drug is being used every day in patients within the NHS. So I'm going to take you through what happens from the drug's point of view as the drug is being developed. So a drug is designed by a clinical biochemist, and then it's tested in a laboratory, and that's pretty basic science testing. So that's really taking a drug and adding it to cancer cells, sat in a petri dish equivalent, or testing them in animals such as mice. But at some stage, you've got to take that drug and start using it in real live people, in patients, and that's what a phase 1 trial is. So a phase 1 trial normally runs for a year, maybe over a year, and involves quite a small number of patients, often 10, 20, 30, 40 patients, something like that. And the first person who goes on a phase 1 trial, first patient, gets given a very, 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 very low dose of a drug. And that patient is monitored very carefully for a number of weeks and watched very carefully for side effects. If that patient and maybe 1 or 2 more patients are okay, if they're tolerating the drug, then some more patients are recruited to the trial and may have a slightly increased dose of a drug. And that process continues. So over a matter of many months, small numbers of patients receive increasing doses of the drug. Because what you're really, from a researcher's point of view, trying to find out from a phase 1 trial is what is the right dose of this drug to be using and what are the side effects. So you can see that as a participant in a phase 1 trial, you're being exposed to a drug that's never been used in patients before. We are absolutely obsessed with safety on phase 1 trials because you've got to be so careful about using new drugs if you can't exactly predict what the side effects are going to be. And that means for a patient participating in a phase 1 trial, they are asked to attend hospital fairly frequently, often weekly, though it varies between different trials. And often a patient's observed in hospital. So they'll have an overnight stay in hospital when we have the drug. And that's so that the researchers, the doctors, can do blood tests, can monitor them for side effects, and do a whole host of different tests to assess exactly what that drug is doing. For example, blood tests to see what the levels in the blood of the drug are, to see how quickly the drug is being excreted, is leaving the body. So more on what's involved from a patient point of view later. When your phase 1 trial is being completed, what you hope to know is what the right dose of that drug is and what the side effects are. And you might have some ideas about if a drug is working well in patients, but that's really tested in a phase 2 trial. And a phase 2 trial, again, involves often more patients, 40, 50, sometimes up to 100 patients. And what you really need to find out from a phase 2 trial, what you're aiming to find out is what the response rates are to that drug. So if you've got 50 patients participating in a trial, you hope at the end of the phase 2 trial to know what if there's 20% of patients respond to the drug, i.e. their cancer stays the same or gets smaller, or what the percentage response rate is. And you also find out more about side effects, of course, because you have more patients taking that drug. Often phase 2 trials are in specific groups of patients. So, of relevance to this audience, often drugs for EGFR positive cancer at this stage for phase 2 will be tested in groups of patients with EGFR positive lung cancer and similar for ALK positive cancer. Now, after phase 2 trial has been completed, you now know what response rates are of a drug, you're very certain about the side effects, you're very certain about the dose. And sometimes a phase 3 trial will be run. A phase 3 trial is different again. This involves often hundreds of patients, takes often several years, maybe many years to complete. It's worth saying the whole process of a phase 1, phase 2, and phase 3 of the same drug can take up to a decade to complete. A phase 3 trial is comparing the drug with another treatment. So what you're really asking as a researcher is, this drug seems to have response rates, but is it better than what we've got already? So to give you an example, for example, if we take example of ALK positive lung cancer, it might be you've developed a new drug, but you don't know if it's better than an existing ALK inhibitor. So you compare the two. A patient enters a phase 3 trial and they're randomized. So they are randomly allocated by a computer system to one of the two arms of a trial, either the drug that we're testing or an existing treatment. That's got advantages compared to the other trials because you're going to get a drug that's been quite thoroughly tested from your phase 2 trial. But it has a disadvantages because if you're a patient taking part, you probably don't want to be allocated to a treatment that's already there in the NHS. You're probably more interested in accessing that new drug. There are ways around that. So, for example, quite often nowadays, people will do what's called a crossover design, where even if you get allocated to the standard treatment, when you've completed that, you can cross over and have access to that new drug. Sometimes phase 3 trials have dummy drugs, placebos, but not often nowadays, to be honest. In fact, phase 3 trials are sometimes not even run for new drugs. And that's because there's increasingly recognition that you can get very good information from a phase 2 trial. And if you've got a rare cancer subtype, so for example, some of the rare EGFR mutations, such as exon 20 mutations, you may not be able to physically get enough patients in one place to run that trial and get the numbers needed. The next step after your phase 3 or your phase 2 is drug licensing. And that's where the authorities, for us, the MHRA, look at all of the information from the trial that's been run and give or not give approval for the drug to be prescribed by doctors for treating that cancer type. The other part to that, of course, is about the funding, and that for us is the NHS funding the NICE approval as to whether, even if that drug's been licensed for using in that cancer type, can we as doctors prescribe it and will the NHS fund that treatment? So increasingly, MHRA will license a drug off a phase 2 trial, so you may not see a phase 3 trial being done. So that's from a drug point of view. That's what has to happen to a drug. Now I'm going to concentrate purely from a patient point of view. And it's worth really hashing out that in the UK and around the world, at any one time, there are loads and loads of phase 1s, phase 2s, and phase 3s running for multiple different drugs. And it just depends what stage of the development of that drug as to what phase of a trial is running. So if a patient is looking to participate in a trial, the doctor treating the patient and the patient look at what trials are available at that one time point. So a patient might go to a phase 1 trial because that's the best trial that's available for them at the time, or it might be a phase 2 or might be a phase 3. I've sometimes had patients saying to me, well, if I pass the phase 1, can I go on to the phase 2? That's not how it works. The trials are running for a period of time. Patient comes and accesses the trial whilst it's available, and the drug development process continues. I hope that makes sense. It could sometimes be a little confusing. So what does it actually feel like, and what steps need to be done to participate in a trial? So I'll talk you through sort of what I do when a patient comes to see me in clinic who's interested in a trial. First of all, it's a two-way process. The patient is assessing whether they want to go on the trial, and I'm assessing for the trial whether the patient is going to be suitable to go on the trial. And what I'm assessing when I meet a patient is lots of aspects of their health, their medical fitness, so how active they are, if they have any symptoms from their cancer, what their other medical problems are, have they had heart attacks in the past, for example, what medication they're taking, all aspects of their basic general health. And the reason that I'm doing that is all to do with this concept of eligibility for a trial, or inclusion and exclusion criteria is another phrase that you'll hear repeated. When I'm running a trial, I have a protocol to follow, and a protocol is 200 plus pages of pretty dense information about, it's a handbook to how a trial is run. It tells you every time a patient needs to come, every test that needs to be done. It's pretty comprehensive. And an important part of that is this eligibility criteria. There are about 20, 30, 40 points that have to be fulfilled by the patient. Now, some of those are really straightforward. Is a patient up and about for a proportion of the day? Are they feeling quite well? Some are more, and things like blood tests. So are they anemic? Are the liver tests okay? Are the kidney tests okay? Some are a little bit more dependent on the particular trial. So sometimes a trial will say you can't be on certain types of medication because they might interact with the drug. So at that first meeting, I'm really going through in general, do I think that patient fits the inclusion exclusion in broad terms? And a patient is assessing whether they want to go on a trial at all. So having a little bit of a discussion like I've already done so far, what are trials about? And then I'm talking in detail about how often they would need to come, what the tests they would need to perform are, what side effects have we seen on a trial so far, what response rates have we seen, those sorts of information. So two-way assessment. If I think that they are going to be a candidate for a trial, I will try and allocate them a slot on the trial, and I'll be trying to pick the best trial for that patient in terms of what phase of trial and what the drug is. And if I can find a slot on a trial, then I'll give a patient a detailed information sheet about that particular trial. It's worth saying, especially with phase 1 trials, it's quite a process to try and find a slot, because as I've said, sometimes if the slot is only a few patients go on, and then you check for okay and you let a few more on. So you're trying to slot the patient in where there's a slot available on that trial, and it changes on a fairly regular basis as to what availability is, especially on a phase 1. If a patient had the information, thinks they want to take the next step, then they will sign the consent form. And then follows, I told you it was a long process, then follows a process of a screening test. So that's a bit like the eligibility we've assessed at that first appointment, but it's going through some more particular ones, some more specific ones to that trial. So it will often involve an echocardiogram of the heart, for example, or some eye tests for some particular drugs that might affect the eyes. And one of the really disappointing things that can happen is if you've got so far in that process and then we find something on the screening test, that means a patient can't go on the trial. And that can be really disappointing because, as you've seen, you've gone through quite a process up until that point. Patient passed the screening test, then they get on the trial. And a word to the wise about the trials themselves, the intensity of what you have to go through on a trial varies greatly. Some phase ones are extremely tough in terms of the time you have to spend in hospital. You know, we have some phase one trials we have to be in for 2 or 3 days in hospital. By the time you get into phase 2, then often these are much less intensive, so the frequency of appointments are less. By the time you're in phase 3, yes, there are extra appointments, but it can feel much more like participating in a normal standard of care treatment. So, when would you think about accessing clinical trials? The really important point is, I think the time to think about a clinical trial is when you are off your standard treatment. So if a patient is doing well on their treatment, their cancer is staying stable, responding, and their oncologist is saying, continue on your drug, then forget about clinical trials. If the cancer starts to grow, that's a time to start thinking about accessing clinical trials. Indeed, on the inclusion I mentioned previously, one of them is almost always that the cancer is progressing. So we don't put patients on a clinical trial unless their cancer has started to grow. We can sometimes have, as researchers can sometimes do appointments before that to have a general discussion, but really to actively think about a clinical trial is when the cancer starts to grow. Where can you access them? Well, most oncologists will have a trial portfolio. They'll be running some trials within their unit. As to how many trials they're running depends on how big their research, how big a part their research plays in their job. So some will have a few and some will have lots and lots. So the phase ones in particular are only run at certain centres throughout the UK. These centres are part of the ECMC network, or Experimental Cancer Medicines Network, because these are the centres which have the facilities and the expertise to run these very complex trials where you have to do an awful lot of safety assessments on them. When you're being referred for a clinical trial, it's worth going on Google Maps and having a look and seeing if that centre fits in with somewhere you can get to on a regular basis. Because if you're having to go to a centre to receive the drug, and all the trial assessments need to be done in that centre where you're given the drug, then it has to be somewhere where you can get to regularly. And if it's a 5-hour drive, then that's probably not something you want to be doing every week. So have a little think about the geography of where you might want to go and look at clinical trials. My main point is get your oncologist to advise you, because the next point is which trial you're going to access. And that is really, really difficult. There's a website that you might have come across called clinicaltrials.gov, and that has every oncology trial that's running in the whole of the world. And if you type in EGFR or ALK into that, then you will get hundreds and hundreds of different trials. And it's really difficult to sift through it. So I would advise you to not sift through it, because it's really hard to try and pick out what trials are relevant, and also not knowing what trials are actually running, because it's not updated in real time and there may not be slots available on that trial. So talk to your oncologist, get their view on what trials are exciting at the moment in your cancer type. They're also best positioned to, first of all, know you and your what are the factors that might affect your inclusion on a trial. But also they're part of that network of oncologists who talk to each other and know what trials are running in different centres. And of course, groups like this, you know, there'll be a wealth of experience about trials from patient colleagues, if I can use that word. The only other thing I think is really important, and I think is also is often an area of confusion, is the nomenclature. So I've kept it really simple, and I've said phase 1, phase 2, and phase 3. If you're looking on information, you'll often see phase 1A, phase 1B, phase 2A, phase 2B. It gets a little bit difficult to work out exactly how far through the trial it is and what's going on. One of the key questions you need to ask when you're talking to a researcher who's proposing a trial for you is really, do we know the dose of a drug yet? So are we in that first portion of a trial of phase 1 where we're trying to find the dose? And then question 2, how far, if we're not in that first part where we're trying to find the dose, we're in a second bit, which is a late phase 1 or a phase 2, how long has the trial been running for? And the investigator will be able to tell you how long the trial has been running and what sort of numbers of patients have been on before, to give you an idea. And they'll also be to tell you about the data that's accessible about the trial to date. And sometimes a trial will be running and will already have some papers published, which will give you lots of detailed information about the trials. So that's my whistle stop tour through cancer drug development. Happy to take any questions or clarify anything I've said.
Thanks, that was very informative. I mean, we've actually got people have submitted questions. Just to say to anybody watching, if you have a question that occurs, do put it in the chat and we can ask it. We can ask it for you. I suppose my sort of first question is, what happens when you actually get on the trial then? So you've passed all the screening, you're on the trial. How long are you on the trial for? What happens then? What if the drug doesn't work? I mean, what's that process like?
Yeah, that's a great question. So, especially if you're in a phase 1, you're monitored very, very carefully, not only for safety, but also for cancer and how the cancer is responding. So often there'll be scans every 6 to 9 weeks as a rough estimate. And also if a patient is not doing as well as you'd hope, then you will scan them earlier. So you keep a very close eye on the cancer. For most trials, it's a bit like the standard treatments for oral TKI, ALK, or EGFR inhibitors. You stay on it for as long as it's working for you. So the cancer staying the same size or getting smaller. For as long as the drug is tolerated, so not too unpleasant side effects. Or the patient can come off at any time on a trial. It's always within their power just to stop if they don't want to participate anymore. There are a few exceptions, but I won't dwell on those too much. If the patient comes off trial, and their cancer is progressing, then I will often go through the same process again of looking and seeing if we've got any other trials that might be useful for the patient. Also looping their own oncologist into the conversation. So taking a step back, looking at what other trials are going on, and maybe putting the patient on another trial if there's a suitable one for them, or getting them back to their oncologist to have standard treatments, chemotherapy, or what have you. So certainly do have patients who come and have multiple trials in the same unit. Just depends on what's the best choice of patient at the time.
Okay, thank you very much for that. We've had a question about patients who don't live close to clinical trials. So somebody lives in a remote area or they're treated at a district general hospital. I think you've sort of answered it, but how do patients whose oncologists may not be tapped into the sort of, clinical trial network find out about trials, and also how do they get onto those trials?
So the practical aspect first, from a geography point of view, if a patient's willing to travel for trial and thinks they can make that journey on a regular basis, we take that at face value. And certainly we have patients who've come from extraordinarily far distances and manage it, and that's fine if they feel they can do that. The other minor point which just occurred to me is that travel expenses in general are paid on trial to a greater or lesser degree. So patients shouldn't be, at a financial deficit for making the journeys. As to the question of how to tap into the clinical trials and to work out what's going on if their oncologist is not familiar, I think it can be challenging. I mean, most oncologists I know are very tuned in to what's available around the UK. But if they're not, then I think it's a matter of looking on clinicaltrials.gov, which is very confusing, I think. But it's about forums, and it's about asking oncologists to refer to a large specialist centre. So most specialist centres will, they often won't accept a second opinion referral, not always. And a second opinion referral is a consultation about taking over care, because often these very big centres have just got lots of patients on their books. But most will accept a referral and give an opinion about what clinical trials they have running in their units. So I think it's about getting the expertise of your local oncologist and asking oncologists for referral to a large tertiary centre for their opinion if you feel the local oncologist is not happy with their knowledge of trials that are ongoing.
Okay, thank you. We've had a question on the chat. When are the results and outcomes of a trial shared with the patient, and is there any additional post-trial follow-up?
Yeah, that's a good one. So the information about a trial is put into the public domain at various times throughout the trial running, sort of, in conferences and publications. When a patient is on a trial, they will get the access to any relevant safety data. So if I'm running a trial, I will do regular calls with the rest of the trial, because a trial might be a big international trial. And if I'm told any safety information, I will feed that back to my patients in real time. At their next appointment, I will say to them, by the way, there's been a safety concern in this, in America, and this is what happened, and, make sure they're still happy to continue on the trial. In terms of after the trial's completed, there is a system whereby you upload the trial information when it's available to patients, so that patients can access that on the web. It's often not done as quickly as perhaps it should be, but it does get there eventually, and that's the best way of finding out after the trial.
Okay, great, thank you. Somebody has asked, how long does it take to get on a clinical trial? I mean, you sort of answered that, but maybe a little more on that one.
I mean, the thing I say to the patients when I see them is I can't guarantee you a trial, but I guarantee I will try and sort it out for you quickly, so that people aren't in limbo. So I can't speak for other centres, but in our centre, we will have a meeting of a patient. We will have a call the following week to let them know how we've got on trying to find a trial. It may spill over to the following week, but really by that point I should have got or not got them a slot, and then after that it's another couple of weeks to get on. So it should be sorted out reasonably quickly. As I can't speak for other centres, but in general, especially for more early phase trials, you need to be moving quickly and sorting it out for people.
And then a more specific question has been asked about EGFR trials. Is there anything coming up in the future that would be of interest to our members?
Yes, probably, but it's a bit tricky, because obviously there's certain information, and I don't want to be plugging any trials in this situation. What I would say is it's a really exciting time for EGFR lung cancer research. We've got new drugs that have been approved recently in for example, exon 20 EGFR lung cancer. And in broad strokes, the trials that are coming through tend to be either new drugs which are targeting EGFR in a better or a different way, we hope, than the existing drugs. Or there's a lot about combinations now, and osimertinib plus chemotherapy, immunotherapy, or newer targeted combinations are coming through. There's a lot that are either in phase 1 and phase 2, and I think results will be coming out over the next years.
Great, thank you. Deb, you've got questions, I know, from some of the ALK members.
We do, yes, and basically very similar question in terms of what trials are there currently available for, or are there many for ALK positive lung cancer?
Yeah, I mean, I would say, but definitely are trials available. There are, in similar ways, the interest is really about either designing better ALK inhibitors, and there are some coming through early phase at the moment. There are also sort of a combination strategies, again, of trying ALK inhibitors plus another drug. I think there tends to be a bit less in the ALK space, and I think that's probably a reflection, unfortunately, of how common the mutations are. But yeah, similarly, it's about trying to reverse resistance to ALK inhibitors once they've happened, and there are definitely some newer ALK inhibitors that you can watch out for certainly in phase 1 and coming through phase 2 shortly.
I would like to ask another question that we've had come through is, we see from our the worldwide site, our US colleagues, they seem to be having many different trials, and Australia seems to be quite a hot spot for studies at the moment, and yet we don't see many come through in the UK. We're constantly being told that it's more difficult in the UK to set up trials, and I just wondered if you had any opinion on that and anything that you can add.
Yeah, I mean, we are, the US can set up trials very quickly. So the setup process, which I didn't mention, is all the stuff that you need to do to get the regulatory approval to run the trial. And the US have been very, very competitive at that and can set up trials very quickly. So we in the UK, one of the real pushes is to try and set up trials more quickly and effectively, to be more competitive, to bring pharmaceutical companies to bring trials to the UK. I think we are, and also they've got more people. So at the end of the day, the drug companies go for where they can set up quickly, and there's a very large populations. I think we've got lots of very interesting trials coming through the UK. And certainly you can sort of see from data that comes out that the UK gets a foot at the table when these trials are published. But it's always, we're always trying to fight our corner, because we want our patients to be able to access these drugs. So yeah, we keep pushing internationally.
Excellent. That's good. Yeah, we had a question around looking at combinations, which you mentioned for the EGFR. I'm assuming the situation would be similar for looking at combinations with an ALK inhibitor plus chemo or plus Avastin, for example. Any comments?
Yeah, no. I mean, I think that's true. Is that combinations are always interesting, because you're taking two drugs that are already there, and there's often a very good logic for why they might work well together, based on laboratory investigations and laboratory testing that's been done. You've always got a bit of a payoff, because if you're using two drugs, they both have different side effects, so often you will have more side effects. And quite a lot of our phase 1 trials will be combinations. And that's something I didn't mention, but that's also something to watch for, because it may be that you're being offered a trial where you've got a drug which is really well known and we know a lot about it, and then adding an extra drug on top. But those can be quite attractive to take part in, because you're getting access to an active drug, and the trial part of it is adding something extra on top.
Great. Thanks, Anna. Right. Jenny, have you got any further questions that come through on the chat?
Well, we've got a couple more questions which were submitted. What happens if you're on a trial, the drug is working, but the trial is coming to an end? Yeah, because it's a year-long trial. So there's something written into the protocol and the contracts that if a patient is benefiting from a trial, that the drug company will continue to provide access. If there's a problem with the drug and it's withdrawn for safety concerns, then that's more tricky. But
And also if a drug is totally withdrawn from production, which sometimes happens, then it's more tricky to guarantee the patient continues access. But that's quite few and far between, because essentially the drug's being withdrawn, that's because it's not working very well, and there's not likely to be many patients who are needing to continue on it. So really, yes, it's very much written in that if a patient's benefiting, then they need to be able to continue to access that drug.
Okay, well, a couple more questions. If you start a trial and then you get cold feet, or you decide that the journey's not bearable, or the side effects aren't bearable, as a patient, what are your options then? If you suddenly think, this isn't for me,
you stop. It's not a problem. I mean, you hope that, you know, all the steps you've gone through to get on the trial, you hope by that point you have really being able to counsel the patient so they know what to expect, so that they aren't surprised when they get on the trial. However, it's always within the patient's remit to be able to stop if they don't want to. Again, you hope to be able to support them through it. If it's something you can overcome by giving them appointments on a different day because one day doesn't work for them, then you try and do that. But if they want to stop, it's up to them. It's no problem. And they're not blacklisted. You know, it's just if a trial hasn't worked for that particular patient and they want to consider another one, then you try and consider another one.
Okay. And then we've had a question about if there's a trial of a drug which may work for you or may suit your situation, but you can't get on that trial because there's no place, or there's no place at the right time. Can you access the same drug on compassionate grounds? Are there any other ways of getting that drug?
Often there's not, because if your drug is in the development phase, those compassionate access or named patient schemes tend to kick in after the trials are completed. However, that's not always the case. So if you've got a drug that's been in some stage of testing process for quite a long time, it may be that there's some trials that are ongoing in some contexts. So for example, you've got a drug that works in lots of different types of cancer, types of lung cancer, and you may find that it's still being tested in, for example, one EGFR type, but it's nearing licensing in another type of lung cancer. You may find that there's an open access program for it as well as a trial running. But it's really difficult to work that out if you're a patient. It's pretty difficult to work it out if you're a doctor, because these named patient programs open and shut all the time. So really, you've just got to talk to your oncologist about it, and often it's a matter of the oncologist actually emailing drug companies and saying, do you happen to have this drug for an expanded access program, which is very, very feasible to send an email off to the drug company to see.
Okay. Thank you very much. We have actually asked all the questions that were submitted. I don't know whether, Deborah, you've got any more questions, or anybody has got anything else they'd like to follow up on the chat.
Okay. We've had one question that was asked within our group is around, they know of some studies, trials that are taking place in Europe. And so the question has been raised as to whether it's possible to access those from the UK.
I'm not sure, because I don't know of many patients who've gone off to Europe for a trial. Okay. I know the other way round is that patients who go on trials in most centres have to be eligible for NHS. So if I've got a patient who's from Europe, I can't put them on a trial unless they've got an NHS number. Okay. So I would imagine that it's probably the same going into Europe. And I can't think of anybody in recent times who's been on. I think there's definitely, I've known of people who've gone off, but I'm not sure if that's because they've actually got eligibility for the health system within that country they've gone to.
Thank you.
So I think it just remains to say thank you so much to Dr. Minchom for joining us this afternoon. I think it's been a very, very informative talk, and I think it will have sort of demystified clinical trials for a lot of people, and we'll also be sharing it on our website. So thank you very much indeed for being with us.
My pleasure. Thank you for having me.
Thank you very much indeed. Thank you.
Thank you very much. Bye-bye.
Bye-bye.